Hello, hello. It's me, Dr. Toomer, and it's Dr. Toomer Talks on Tuesdays. And thank you for joining us. And if you're here, say hello. If you are watching later, just put in hashtag replay. And today we actually have a really good guest who's here to talk to us about stress and mental illness and weight. And she's a psychiatrist, so she's definitely qualified to talk about this. And we have Dr. Vineka Heeramun. Did I say your name correctly? I
You
forgot
got
to
it.
ask you before we came on. And she is the CEO of Joyful Horizon Psychiatry. And so I'm going to let her introduce herself so we can just get right into it because this is a topic I think that is very important to many people, as those of you who've heard me talk a lot about biopsychosocial approach to weight health, and but it's all health. So mental health is health, and so we're going to talk a little bit about that today. So tell us
Hi,
about
Dr.
yourself.
Tumor. Thank you so much for
Hello,
having me on.
thanks for coming on.
So I'm Vineka Heeramun. I'm the CEO and owner of Joyful Horizon Psychiatry. We are a psychiatry clinic, actually two clinics now in Utah at two different locations, so West Jordan and American Fork, and we focus on treatment-resistant depression. And the just a little background there. When I finished residency, so I graduated in. I had my dual board certification for so internal medicine and psychiatry, and then went into inpatient psychiatry after I was done with residency.
Hmm.
Uh, I did inpatient psychiatry for about 8 years, and I really enjoyed it. I was taking care of the acute unit, so that was schizophrenics, bipolar patients, violent patients sometimes, and was also in charge of the geriatric unit. Now,
Hmm.
with COVID, that unit had to close down because there were so many restrictions, and especially with the nursing home situation where we'd send the patients back or take them from the nursing home. And that unit turned into the women's unit. And there, what I noticed was that a lot of patients were struggling with chronic depression. And the inpatient unit was like a revolving door. So we'll stabilize them, they will come in because they're suicidal, and then there will be a lack of follow through. So maybe not having enough resources or insurance issues, so they wouldn't be able to follow up with a psychiatrist or therapist, and soon they'll be readmitted. So I was wondering, how can I break this cycle? So then I transitioned to outpatient psychiatry this year. So I'm fully outpatient now. And one of the big things is to try to uh, keep the patient stable on the outpatient unit. So how can we maximize their potential? How can we keep them going so that they don't decompensate so much that they end up on the psychiatric floor? So depression, anxiety, that's kind of the bread and butter of psychiatry, and you name it, stress. Our topic for today is that's all we hear. It feels like.
Well, before we continue, I'm going to say hello to Chris, who comes every week, and I appreciate it very, very much. Um, so wait, so you said that you started your outpatient practice this year,
I went fully outpatient this year. I
and
started
now
it.
you have two clinics now.
I have two clinics now.
So that's, so basically you're a star entrepreneur then, as well as a star psychiatrist, because that takes some, that takes some quite some business acumen to do that. For anyone who runs a practice knows that, growth like that is pretty significant.
Well,
Um,
the need is so much in the community because there's a lack of psychiatrists
mm,
everywhere, and including Utah. So the need is so much. And I used to work about 45 minutes away from home, so in a different county. And when I moved to my county, then patients were like, oh gosh, you live too far. We need the care as well. So I opened a satellite location just to make it more reachable.
mm,
But there's still like if I could open more locations, just clone myself, I would do that because the need is just so
yeah,
much.
yeah, I agree. And so tell me, for when a lot of times when people say depression, they think, oh, it means sitting around feeling sad all the time, or it is crying all the time, or, what are some of the signs of depression that most people may not recognize as signs of depression, and maybe walking around with it? And then if they do have depression, at what point should they seek help for it?
So the depression is usually equated to just sadness, but
Mhm.
it's a confluence of symptoms. So sadness is just one of it, and usually it's not just feeling down, like there's somebody got fired and they feel down and they feel sad. That's not depression. That's a situational depression, or like an adjustment disorder, we call it. But when the depression is persistent, the DSM classifies it as more than 2 weeks of sadness continuously. That would be considered depression, but not by itself. So there are other things. For example, um, people start feeling really tired, lethargic. It's a drag to get up in the morning. There's no motivation. It's so hard to even do basic tasks. Everything looks like, oh gosh, why is it taking me so long? Difficulty focusing. Um, Also accompanies changes in appetite that we would get into, and then changes in sleep patterns, so difficulty falling asleep or staying asleep, multiple awakenings at night. The appetite can be either decreased appetite or increased appetite. And same with sleep, decreased sleep or excessive sleep, where people usually sleep 7 to 8 hours, now they're sleeping for 10, 12 hours. Then there's that feeling of worthlessness that starts to become incapacitating. And then the most concerning one is when the patient starts feeling suicidal. And at that point, they're feeling like, okay, I'm not a good person. I can't do anything. I'm a burden to society. I'm not a good mother. I'm not a good wife. And in their mind, they rationalize like, well, it's not. I'm. It's better that I'm dead. That I
Mhm. People are
keep
better off without me. Mhm.
exactly. At that point, definitely we are in probably hospitalization mode because the patient is not safe, and it just takes a little bit for the patient to maybe attempt suicide. But even before that, um, just with some of the symptoms appearing, so not just like the sadness or not just crying, but crying multiple days in a row, feeling like, just as I was saying, the feeling like a drag. This is time. The earlier people get the help, the better, because it affects their life much less when they get help earlier. Because by the time they're suicidal and need hospitalization, everything has to change around them. Like they not wasted, but I would take it as, you need to spend time in the hospital. Then you need to take time to kind of readjust to the outpatient world when you go back. So the earlier you can seek help, and that help can be, first of all, just talk about it to the people around you, to your surroundings, because a lot of people with depression, they isolate themselves. They don't want to talk. They just want to kind of stay to themselves. So, and loneliness perpetuates depression multifold. So the
Yeah.
first thing is they talk to it to somebody that they trust, um, and then the next thing would be seeking therapy. Now, even though I don't do too much therapy, I leave it up to the therapist, but I'm a true believer in therapy because I think a lot of the things that creates like neuroplasticity changes in it just takes a long time, but those negative thought patterns that we tend to have, like for example, I'm not good enough, oh gosh, I should have done more, these things can be changed with therapy, like cognitive behavioral therapy or supportive therapy. And it works much better, I think, with a combination of therapy and medications rather than just medications,
Yeah.
because there's no magic pill that will lift somebody out of their depression.
Yes. And one of the things that I've often mentioned, and you can tell me if I'm accurate in this assessment, that part of depression is also a feeling of worthlessness, or uselessness. And especially when you're on a health journey, if you don't feel like you deserve to be healthy, you don't feel like you deserve to be successful, then you lose the motivation to then do anything about it. And so it does feed on itself. And so when you're on a weight loss journey in particular, which is what I deal with most, um, getting your depression treated is often really important, or at least recognize that it's there is really important even before starting your process, which is actually what I did. Um, I Before I was able to lose weight, I had to get my depression treated, and so which is why I'm so adamant about making sure that we test everybody. I mean, because that's one thing you just don't want to leave. And like you mentioned, the earlier you catch it, then um, the better off someone could be. So then you mentioned treatment. Many people, and many times when I do diagnose someone with depression, they don't want to take medication because they're worried it's going to make them gain weight. Um, and anyone who knows me knows that I do like bupropion because it tends not to do that. Um, so can you talk a little bit about that and when it shouldn't matter, but um, some of the medications that work better than others that may have less of a weight gain process with them?
So there are, yeah, multiple classes for antidepressants or augmenting agents. So some to that obviously cause weight gain would be things like Remeron, and we actually use it um, to help patients like to gain appetite. So for example, like an elderly patient who has difficulty sleeping and has poor appetite, that's a good fit for them. But for somebody that's trying to lose weight, that's the opposite. Like we don't want to initiate that. So if they're having difficulty sleeping as well, then choose something else. But for the antidepressant properties, Wellbutrin is very good. So bupropion, as you said, which is an NDRI, so it binds to the norepinephrine and the dopamine receptors. And the good thing with addressing the dopamine receptor is in people that are stressed or depressed, there's or I should say the atypical depression. So the patients that tend to have increased appetite and emotional eating with depression, as opposed to those that have a loss of appetite.
Hmm.
So they will go towards the comfort food because they're feeling so overwhelmed, they're feeling low. So the food represents a friend, like, oh, a little bit of dopamine, maybe I'll feel better if I eat it. But we know that's just transient because later there's going to be a lot of guilt and then the weight gain associated with it. So dopamine helps with that good feeling because of the release of dopamine, but also because it increases energy, it increases motivation. Now, with the SSRIs, not all SSRIs are equal. One that tends to be more, that tends to cause more weight gain would be paroxetine.
Hmm.
And again, it's really good for anxiety, but not so much if
Much.
somebody's aiming to lose
And
weight.
that would be Paxil by the brand name that most people would recognize. Is that correct?
Yes, exactly.
Okay. Hmm.
Whereas Prozac, for example, tends to be more weight neutral. Zoloft as well tends to be more weight neutral, but everybody's so different. When you look at the list of side effects from all the medications, it will tell you weight gain and weight loss. Now, what will it cause in which person? We don't know until we try, but
Hmm.
some we know for sure have a predisposition to the weight gain.
Okay.
Even with bupropion, I've just had one patient actually that gained weight on it, and I was so puzzled. We did anything else going on? Let's get your thyroid checked again. There was no new change, just the initiation of bupropion. But
Hmm.
99% of the cases, and by its mechanism, it tends to cause weight loss, and that's why it's a component even in some of the medications, like in conjunction with, let's say, naltrexone or something. The bupropion helps with the weight
Hmm.
loss. And
Yes.
then when choosing, for example, an augmenting agent, so we use an agent that helps augment the effects of an SSRI, for example, then choosing something Latuda, for example, which is lurazidone, which tends to be weight neutral, is
Okay.
better than going for olanzapine or Zyprexa, which tends to cause weight gain.
Okay.
Um, and then there are also some things to avoid, for example, the TCA, so the tricyclics antidepressants.
Mhm.
One example is amitriptyline. It's used for not only depression, but sleep or
Yes.
migraine. So
You
these
a
tend
lot.
to
You see it a lot in sleep for as a sleep aid in
be,
primary care.
yes, for sure.
Mhm.
And but out of all of those, consistently, bupropion is the winner, in that it tends to um, decrease weight as opposed to cause weight gain.
Okay.
Um, in the caution with that, because it's activating, it provides that energy and that motivation. Plus, uh, I would just caution to watch out for if there's any increase in anxiety.
Anxiety. Hmm.
But a lot of times, the people actually report decrease in anxiety because now they have more motivation, so they get more work done. So as a result, their anxiety also goes down. So it's just a fine balance with maybe the dosage as well. Maybe the higher dose would cause anxiety, but the lower dose won't. But definitely something to keep on the table,
Hmm.
if even if somebody has anxiety as well.
Okay. And before we continue, I'm just going to say hello to my aunt Cynthia, who's uh, tuned in, and don't worry about names. We're good here. Um, so one of the things I do use a lot of bupropion or Wellbutrin. It's actually my even before before even Contrave, the weight loss version of it came out. I used it quite a bit. Um, but one of the things I found, and you can tell me if you've seen this or maybe it might just be in my head, but depending on whether it's immediate release, sustained release, or the XL version, changes how much anxiety may be seen, or and how much appetite suppression and OCD, like more of the compulsions, tend to get treated better with some of the different iterations of it. Now, do you see that? Because I tend to like the SR,
The
but I
SR is
don't know.
by
That could just
far.
be me.
No, it's a favorite even amongst patients. So what's frequently reported, so the immediate release is one to avoid, except if somebody needs the lowest dose, just you're just trying something. I
Mm-hmm.
wouldn't even use the immediate release, because what happens is that because of its short half-life, there will be a dip even within the day. So the patients will then feel really dragged down and tired even within the day. Kind of like taking a stimulant, immediate acting stimulant, like Adderall or Ritalin. Then the sustained release, patients feel the effect of it,
Mm-hmm.
without it making them too anxious, and they're still able to sleep at night, because remember, again, it's activating, so we want to also assess for insomnia. Whereas the extended release, there tends to be more insomnia cases, because if somebody is a slow metabolizer, it will stay in their system longer, and that can affect their sleep, which would defeat the purpose of, if whether we're trying to uh, treat depression, because we want them to sleep well, because
Mm-hmm.
getting the sleep address will help with the mood, but also addressing the eating habits, because with good sleep, then the cravings become less as well. So some people like it because if they're fast metabolizers, they do see a dip in the sustained release version. But for those people, I tend to do twice a day dosing. So
Mm-hmm.
in the morning, and then do one mid afternoon, not too late, so that they can still sleep. But in general, I think that the SR version, so the sustained release, works
Mm-hmm.
better
Mm-hmm.
and has less of that on and off phenomenon like the immediate release does.
Okay. And so, just to sort of reiterate some of the things that you said, because there were a few that came on a little bit later. Hello, Daphne. Um, so early recognition, early treatment, better than letting things go too far because it will snowball otherwise. And that there are various medications that can cause weight gain. Mostly they're in the SSRI family, but um, medications like bupropion or Wellbutrin can be beneficial, and depending on which um, release you use can also determine whether it's a good medication or not. And then with the eating and sleeping and the stress eating or stress sleep, or stress non-eating, that's something to pay attention to. So my question now is, where are you? How can people find you? And do you only have information or assistance for people who live in your area?
So you can find me at on the website joyfulhorizon.com, Instagram Joyful Horizon, TikTok Joyful Horizon. There's
Nice.
joy everywhere. Right now, we only provide services in Utah, and that's because we provide those treatments for like treatment resistant depression called TMS and S-ketamine, so Spravato, which is an intranasal ketamine, and a TMS, which is transcranial magnetic stimulation for people that had failed multiple medications.
Mhm.
So those are only available if somebody can come into the clinic.
Okay.
So right now we're only available. Our services are only available in Utah, but I have done virtual. I just don't have. I'm not licensed in different states
States.
right now, but I can see patients virtually in Utah as well if they are not in those two counties where the clinics are at.
Oh, okay. But on TikTok and Instagram, do you have information that people can still consume even if they don't live in your area?
I'm working on this
Okay.
as an as a as an introverted introvert. I am very
Yes.
hard to go on social media. It is a process.
Yes. It is. It very much is. I was there once. I kind of just forced myself, and now here I am doing lives every week. I mean, I never would have thought that was going to happen. So,
I'm gonna put you
um,
on my vision board. That
yes.
way, in a few years, I'll be doing live every week as well.
Oh no. Uh, well, thank you so much for coming. I really appreciate it. And I do want you to come back. I feel like there's more to this conversation that we need to have. Um, and Because I think that um, it's largely, depression is largely underdiagnosed, undertreated, and particularly in women often, well, like I think really just about in everybody. One, because men avoid doctors in general, and then for many of us as women, we assume that the symptoms are normal. We don't like them, but it's like it's just part of life. And so I'd love for you to come back on and we can talk a little bit more about that.
Thank you so much for having me, and thank you for the future invitation.
Yes. Okay. And I'm going to hold you to it.
Oh, I know
All
you
right.
will.
Well, thank you all for coming in. Thank you for coming to Dr. Tumor Talks on Tuesday. Chris and Aunt Cynthia and Daphne, thank you for joining in. I know there's others who are listening who haven't kind of chimed in, but that's okay. We'll get you next time. All right. Good night.
Bye.
It's always a challenge trying to turn this off.